October right now, we'd be pretty happy on this front. So we need to talk about this with a sense of urgency. Please bring it back to your churches. Please bring this conversation, anything you heard today that pierced your heart around your dinner table, bring it back to your offices at your next staff meeting and share some of the information, or that we're never going to get the message all the way across. And that's very important. Blue dots are overdoses, red dots are I talk all the time about the red dots. Our goal of the Opioid Task Force, the Monroe County Heroin Task Force, right now is simply prevent the red dots. And we can just slow down the number of red dots, the number of deaths. This is only 1 month, 30 days, Monroe County. You've heard it many times. Look at the dots. They're spread across Monroe County. We had an off-duty deputy driving home in Mendon on Friday night. Car stuck in front of him, wouldn't move. Finally got out of his car. The deputy went up there. And there's a guy in Mendon at Four Corners with a needle in his arm, passed out. Had to break the window, administer Narcan, emergency room visit. This story, that's another dot up here. That's in the town of Mendon on a Friday night on the way home. So if you take that and you illustrate that just for April, it's even more. That's this year to date, end of April, beginning of May. We haven't even captured the numbers for May yet. Now it's centralized around urban areas, obviously, it's supply and demand. But all these people, I can tell you, are not from the urban area. I just used Mendon as an example. You can almost see the 390 corridor going down to Livingston County. These people are ODing en route to drive back home. They can't wait to get home to get the next fix. If you think about this addiction, and Dr. Mendoza nailed it, this is not a party drug. People are not going out smoking marijuana, getting high on cocaine, and going dancing on Friday night. Hold your breath right now for 30 seconds. Don't really do it. Hold your breath for a minute. You would do anything to breathe that next breath. This is what this addiction feels like to a person addicted. Think about that. You will steal from your mother. You'll steal from your grandmother. You even take a substance that may kill you, red dots. You know that, but you're willing to take that substance to get that next breath. That's what these people are suffering through. So what do we need to do in law enforcement? District Attorney created this simple form. It's captured every time there's an OD anywhere in Monroe County, an overdose, whether it's a red dot or blue dot, we fill out a simple form that's shipped off downtown. By 8 o'clock in the morning, the Monroe Crime Analysis Center is already analyzing that. So we have real-time data, not 6-month, 7-month-old data. We know what happened last night. The analysis looks like this. We know the person that's the victim of the OD. We probably have some cell phone information on the drug dealer. We're correlating that cell phone information with other cell phones that might be on the opposite side of the county related to another overdose we had. We're looking at the package descriptions. We've already been on the Facebook accounts. We're looking at the Facebook accounts of both parties involved. We're already looking at our intelligence database from prior arrest. We're looking at jail information. Who's in jail, who's not in jail, what information's in jail. And by 8:30 in the morning, we have a complete picture of what occurred the last 24, 48 hours. And what we created to react to that is what we call the command post. The command post is represented by a lieutenant from the Monroe County Sheriff's Office, a sergeant from the Sheriff's Office, and 4 dedicated deputies. The Rochester Police Department has dedicated officers. Gates Police Department, a dedicated officer. Ogden Police Department, dedicated officer. Monroe County District Attorneys, several dedicated investigators. And we work hand in hand with Brett's team, who's the Greater Rochester Area Narcotics Enforcement Team, but this heroin task force is specifically after that intel that occurred last night. That's their sole mission. They don't answer 911 calls. They don't do anything else. They look at that intel that was gathered and generated and analyzed, and they get an operation brief by 9 o'clock in the morning. Well, how are we going to react to that? We're going out and going to grab the families that have a son that just OD'd last night. Are we going to be in support mode for that family? Do we bring our nonprofit friends with us? Are we going to target the drug dealers? And what kind of case can we put together? How are the cases related together? This, if you're in the military, this looks like a military operation. By 9 o'clock in the morning, people are looking at that information. Full-scale boards, TVs up, pictures up, faces up, Facebook accounts up. It's a beautiful thing. These guys are going out every morning trying to react to that real-time intelligence. So that real-time data, what's that gathering us? We've been running this for 3 months. This command post has been up and running for 3 months. So far, I just got the numbers about 2 minutes ago. We've taken about 268 grams of fentanyl/heroin off the road. What does that mean? It's about 5,000 hits. 5,000 hits of death that we were able to take off the road in 3 months. Who knows what's going on? And supply and demand, about $274,000 have been taken off the road from drug dealers, taking the money out of their pocket, hopefully putting it in some back pockets. 274, almost, we're talking coming up on $300,000, $100,000 a month we're able to take off the street. This is a very lucrative business. People are selling death. They're not selling cocaine, they're not selling marijuana, they're selling pure death to people. So we're going to go after them any way we can. The district attorney already hit what she's doing. She's trying to put prosecutions on these folks for homicide charges. Why homicide charges? Maybe less than the sale charge. maybe a little less felony. We want to tell people you serve death in Monroe County that we're going to charge you with a death case, plus the sale, plus the possession. We're going to get you with every felony we can get you with. So we can't do it alone. I seen on the brochures floating around, there's a beautiful brochure by the Monroe County Opioid Task Force. There's just wonderful partners out there. If you have anybody in your family you think might be becoming addicted, you have anybody in your family, your friends, your coworkers, your church, do you think might have issues? I tell parents all the time, they ask me, how do you know your son or your daughter is having a problem? I always say the ATM, the bank account tells you first. This is a very expensive drug. This is a very expensive addiction. Where's the money? Are you missing things out of your house? Is your ATM being drawn? It's probably the first clue you can have right there. The money talks on this one. The second thing we can talk about all the time is there's wonderful people out there willing to intervene. I have one dedicated deputy. All he does, we made a significant arrest the other day in Greece, and a deputy at the exact same time was answering a Facebook account hit. A mother in Penfield was dying to get her son out of Brockport, who she knew was addicted and was living in Brockport. We sent a deputy out there and we did what we call a kidnapping, but it's not legal kidnapping, DA. We snatched and grabbed that young man for the mother that's over in Penfield. They couldn't get him, and we brought him to one of our beautiful beds here in Monroe County that hopefully will keep him from being a red dot someday. So that's what we're trying to do. Keep this in mind, folks. I could talk all day long on this, but the numbers are phenomenal. The arrests are phenomenal. We'll keep on doing that. We got to shut off the well. You got to help us with the prevention. You got to talk boldly about this. Share that. If people don't understand because they don't have any family members addicted, get in their wallet. What's in it for them? Talk to your family, friend members that it's not my problem. Ask how much each one of those dots cost you and your taxpayers. Right? For the police officers, the district attorney's office, the public defender's office, the courts, more than $105 to incarcerate them in the jail. That's if they have no issues. All right, long-term incarceration, recovery beds. You can't even imagine how much this is costing each one of us as tax dollars. So keep that in mind if you're talking to people that don't really understand addiction. Talk to them about their wallet, they'll understand. So we can motivate anybody to get involved in this. Thanks, guys.
Thank you, Sheriff Baxter. Up next, Elizabeth Kingsley Curran is a licensed master social worker, credentialed alcoholism and substance abuse counselor, master counselor, and holds an international certification and reciprocity consortium certificate. With more than 15 years of experience, Elizabeth is dedicated to working with underserved populations, including individuals with persistent mental illness and substance abuse disorders throughout Rochester and surrounding counties. Elizabeth is currently Director of Admissions at East House. Elizabeth earned her Bachelor of Science in Sociology and Health Science from the College of Brockport in 2002, and her Master of Social Work from Roberts Wesleyan College in 2011. Please welcome Elizabeth Kingsley Curran.
Well, good morning, and thank you so much for having me here. One of the first things I noticed when I walked in this room this morning, I see so many faces that I see on a regular basis that I advocate with, and so it's just amazing to see so many different people in the community come together to an event like this to learn and to discuss, because as we've heard numerous times this morning, the most important thing that we can do as a community is talk about it, to share with each other experiences, personal, professional, because many of us do have those experiences. And within that sharing, there is so much power, there's so much wisdom that we can collectively use in terms of prevention and discussion. And as you know, from a business community, to be able to have this opportunity to have this mission, because it takes many members of our community. And it's true that businesses are leadership, a form of leadership in our community. So I wanted to share today some education. Having said all that, how important education is in our community, recovery is, there isn't a single way in recovery. It's someone's own journey. It's an experience. But the most important resource for individuals, for families, for treatment providers, community members, is to know what type of resources are available, how to get treatment and help. I spend a lot of my day internally inside our agency working within our residential programs, but a lot externally in terms of systems related to levels of care within the OASIS field and how do treatment providers work together, because the warm handoff, the collaboration, the communication is essential. And so when one person, as we discuss these levels of care, they're all important and they're all crucial, but also what matters just as much as each of us do is the communication in between. We cannot let people go without having that conversation and that loss of contact is something that we really have been spending a lot of time on in our meetings with the county and with providers, because that's crucial time when people are ready to go to treatment. Time is of the essence. We've spent a lot of time this morning talking about time, but when someone is ready to go, waiting is not a good option. It's not the best option, right? And so we do have numerous different providers in our community. Walk-in evaluations and open access, which is on the opioid task force brochure, is one of the beautiful things that has come out of collaboration. These walk-in evaluations are now open 24/7. And so while we have community providers where people can call and schedule, I do have treatment grids today. DePaul NCADD provides these. I would encourage you to look those up, or I have a couple of copies. But either way, an evaluation is one of the first steps. And so I have lots of people call me regularly from our community. You know, they may not be sure if their son or daughter or family member is struggling. They themselves may be, but oftentimes it's the family members. Someone may have recently been involved with the legal system, maybe had a recent hospitalization ED visit, and they're given information and they don't know, what do I do? And so I really spend a lot of time talking with individuals. And the difference, I worked with a woman a couple of weeks ago, and she had called to ask about, you know, I got this piece of paper and it had your name on it. And she said to make an evaluation. And I, what do you mean it has my name? So she was discussing the resource grid that I'm sharing with you. There's lots of different providers. And she was asking me, how do I make an appointment? My brother's in trouble. And we were discussing and sharing, and Dr. Mendoza shared the image of the brain and the impact of use, particularly with cocaine, but with individuals that are early on and in treatment and have recently been using, their thought process, their thinking, it can be very difficult. So rather than putting this solely on the person that's struggling with the illness, you call and you make the appointment, you get to the evaluation. Significant others, loved ones, are often the people that call and make those appointments, and that's okay. And so this woman and I were discussing, and we were looking at this grid together and talking about where do they live, insurance, and she shared a bit more with me. And so through that conversation, I said, you know what, there's this open access. So you have an option of helping him schedule an appointment, but I gotta be honest, this might be a potential ED visit if we don't get to the open access clinic. They will help with an evaluation. You can go anytime, that's the beauty of it. So waiting for that appointment and doing that is great, and have that availability and that accessibility, but the immediacy is often what matters. And so those are the biggest takeaway from today, is that the importance of starting with an evaluation. Our evaluations will provide the diagnostic assessment. They'll provide treatment recommendations, level of care, but those evaluations are absolutely essential. And oftentimes they're the beginning of treatment in our community. Not always, because this is not a linear process in many different providers, but it's important to know what type of level of care and services people provide. There's some misunderstanding. There's some when people talk about beds in our community, I'm always very specific and say, what bed do you mean? Because when we have that specific language and we know what we're talking about, we can get people to the appropriate level of care. Because one of the most detrimental things is to have someone in a level of care that's not indicated, that's not helpful for them, and so the cycle can continue to begin. And so the goal is to work together to get someone into the best treatment possible. However, they see that treatment is the most important. So one of the levels of care that people utilize is Detox. It's medically managed, staffed 24/7. These programs are very, very short term, very short duration, a couple of days. And so people go there, really medical management of severe withdrawal symptoms or risk of severe withdrawal symptoms. So many people, substances, opioids, alcohol, benzodiazepines, there's numerous different substances people go to treatment for to receive this medical management and supervision of withdrawal, because many people, seizures, the risk of death from withdrawal symptoms is exponential. And so that short period of time for that stabilization is crucial for the beginning of treatment, but also for the ending of using a substance. Inpatient treatment is a bit longer, and sometimes people may go directly to inpatient, they may go directly to detox. Inpatient is 24/7 staffed. It also has a medical model where people also have access to medication-assisted therapy and treatment, as they do in detox and other settings. But this is more of a longer duration than detox, and individuals really, here is more of a stabilization period where they're getting some psychoeducation, they're getting some more time for continued healing early on in their recovery. And so lots of psychoeducational groups, linkage here between, most often, next level of care, and each level of care there's discussion about what's next. That's always the individual in recovery's next question. That's also the treatment providers. That's legal system. That's family supports. What's next? What's next? What's next? So as I mentioned earlier, outpatient is a place where people can get evaluations, but also it's a component of ongoing treatment. So from inpatient, sometimes people are referred to outpatient, they may begin there. But outpatient programs have multidisciplinary teams. There's usually a medical director. There's nursing staff oftentimes and counselors. The counselors who provide individual and group therapy on a daily basis. We are very lucky in our community to have the outpatient providers that we have and that we partner with. And so they bring tons of expertise and experience within these multidisciplinary teams. Individuals go to counseling, group counseling, individual counseling. Many different agencies provide different phases of treatment within that. And there's routine conversation as it relates to someone's progression, how someone is responding to their treatment plan. And they may also at this time be referred again to another level of care, oftentimes residential programs. So residential services. So in our community, we again have several resources and levels of care. And these levels of care in terms of residential people are in need of these settings for the structure, for the support. They may, most likely, they're often referred because they do not live in an environment that's conducive to recovery. So the importance of the warm handoff and the discharge planning, because when people are discharged from detox or inpatient back to a setting that's not conducive to recovery, what do you expect? What happens? Those same stressors, those same struggles, that same environment is continuing to impact that person. And so residential settings provide that safe place for recovery, the experience that they can have in a safe environment, and a therapeutic way to help with their recovery. And so in our OASIS, the Office of Alcoholism and Substance Abuse Services is recently going through a massive redesign. And so that's added to some confusion in our field, even among providers, quite admittedly, among these changes where what's happening in our residential field and with that realm are really all for the best of the treatment with individuals that are struggling. Really involving some more integrated programming with internal resources, but also externally with community providers. And so a residential setting that involves stabilization, it's again a short duration, short-term or longer-term, meaning weeks or days, depending on the program, depending on insurance, depending on where the person in recovery is at, and that may not be necessary. But stabilization is 24 hours a day, 7 days a week. Again, there's medical management, moderate withdrawal in individuals. There are really, they sometimes go there and they are able to have medical management of withdrawal, medication-assisted treatment. Again, this is a place of continued stabilization, and stabilization is the level of care. But from this, often individuals transition to rehabilitation. So in a way, a continuum and phases of treatment. Rehabilitation is a setting that includes continued medication management, including individual and group and family counseling. This programming is very intensive. I mean, folks are up, we were all up very early this morning, but they're up very early beginning their day. Groups, treatment, different psychoeducational groups, recovery groups, and it's a pretty intensive place where people get that support and go through a lot of the work in their recovery. And then people transition to reintegration. And currently in our field, reintegration right now is community residence and treatment apartments. So people sometimes refer to them as halfway houses. But reintegration is a place where folks transition from structured treatment and patient detox into a setting that, there's residential, the service is 24/7 in terms of staffing and community residences. Treatment apartments have on-call. But folks have really worked through many phases in their early recovery. There's continued stability. But the goal here is to include the clinical and social services in the community. So really integration of our care and community collaboration. So this again speaks to the continuity of care, the collaboration among treatment providers, and the use of supports in our community, because there's many, and I think that the Opioid Task Force brochure will indicate to you numerous different types of supports. But the peer support, I think that was mentioned earlier, is absolutely crucial component and part of this treatment. peers. Recovery Fitness is a newly formed, wonderful place where individuals can go, and many people I've seen over the past couple of years, people really become very involved in Recovery Fitness, volunteering, going there, but individuals that are in recovery and have that experience of community and of doing something with others is absolutely empowering, and it's a way to integrate what they've learned from treatment, where they're at in their recovery, into experiences. Gates to Recovery. There's recovery supports, peer supports, and family navigators, which are absolutely crucial. So what I shared earlier was one example of someone discussing with me, what do I do? But there are resources to help people navigate. So I'm regularly, I may end a conversation with somebody saying, you can call me back anytime, but let me give you these numbers so that you have someone to walk with you and through these levels of care, because it can get scary, it can get confusing, and every system, let's face it, that we all interface with, may not be the most easy to navigate or the most transparent, and it's confusing. When you're experiencing a crisis for whatever reason, and particularly as it relates to addiction, it's incredibly difficult. So to have that support, and the family navigators. So there's peers who work with individuals and also with families, and families are a crucial component in terms of treatment. They, in some cases, really are the folks that help family members get into treatment. They're the support, and they're really something that's integral as it relates to a person's treatment. So the, overall, the importance of education, I wanted to give you an overview of resources in our community. They're brief intention. The OASIS website has details, and NCADD has the grid specifically related to levels of care, direct numbers, if that's something that you need. But that would be a great resource to have for quick access, and especially the open access number. And in addition to Narcan, I have to echo the importance of training, and if that's something that would be valuable, that you think would be valuable at your site, I would encourage that. So thank you so much.
Thank you, Elizabeth. Up next, and he wanted me to say, saving the best for last, right, Brett? Brett Sobieraski, a Rochester Police Department Sergeant, is a member of the Greater Rochester Area Narcotics Enforcement Team. He's been a police officer for 30 years. Sergeant Brett is presently an RPD sergeant assigned to the Granite team, as I said, a multi-agency drug task force. He's been working and supervising narcotic investigations for over 20 years and has been instructing drug identification and awareness at the Monroe County Police Academy for the past 15 years. Brett is currently a board member and past board chairman at Huther Doyle, upstate's largest outpatient rehab clinic. Please welcome Brett Sobieraski.
Good morning. I'm not sure I can stay behind this podium. I move around a lot, but I'll talk loud if I move. I just want to give you a little background on myself. So I'm a sergeant with the Rochester Police Department. I'm born and raised in Lockport, New York, so I was a policeman out there. My dad was a policeman. I was second generation. Back in the early 90s, I came to Rochester. I was always looking to do narcotics work, and I was lucky enough in the mid-90s. Grew my hair out, down to my shoulders, past my shoulders, earrings, beard, and then had the greatest time of my career for 2 years. Buying drugs, getting locked into drug houses, kicking in doors. It was just like living a TV show. And then unfortunately I took the sergeant's exam, so I got promoted, cut my hair, shaved, they kicked me out. And within a couple of years I was back there in the late 90s. So I've been, out of my 30 years, 20 of it has been basically doing narcotics enforcement at the street level. My son's a policeman, so he's a third generation. We have this twisted chromosome in our family, so we just can't get out of this field. And I'm assigned to Granite, which is, so I work for the city, they pay me, but I work for Granite, which is the Greater Rochester Area Narcotics Enforcement Team. So basically, I have a bunch of folks from the suburbs, or the Sheriff's Department, Brighton Police Department, Greece has a couple officers, the DEA, Border Patrol. So I work throughout all of Monroe County. I've done investigations in every single jurisdiction in this county and sometimes throughout the state. So my view is really of Monroe County, not just the city. I've probably been in over 4,000 drug houses, like kicking in doors. I bought drugs hundreds of times. So I was here when this started, when this epidemic. Like I have a view from the ground how this happened. And I'm also, like I said, back when Bob Duffy had the drug summit back in the early 2000s, Huther Doyle asked for a representative from the police department. So I joined that board back in 2001, and I've been there ever since. And we, a lot of times we are very parochial in our thinking in law enforcement, but I realize no way we're wrestling our way out of this. Without rehabilitation, without a very strong preventive piece, like we're not getting out of this. So we'll talk about, that was me, I had hair, see, I told you. I had hair, I had beard. That was like early 90s. 20 pounds later. So heroin was the illicit drug of choice if you reverse time and go back to 2005 or the early 2000s. That was the illicit opiate of choice. It was mainly, there's two areas you could buy it in the county for the most part. It was either the North Clinton Avenue corridor or over at J. Broad Street area. That was where if you wanted to get heroin, you would buy it there. Not to say that it wasn't sold in other parts of the county, but primarily those were the places. It's this tan powdery substance. The first time I bought it as an undercover officer, I remember looking at how little there was in what's called a deck, and we'll talk about that. And I thought I got ripped off when I looked inside of it. And there's only 0.02 grams. It's this really fine, it's almost like fine, like baking powder substance. And I was like, oh my gosh, that's so little, how do you get high on that? And now you can understand why people can overdose on heroin itself if a dealer put too much heroin in there. Because these decks of heroin aren't being filled by people in lab coats. They're being filled by drug users who get paid with heroin to fill these bags up. So the quality control is definitely not there. So now we talk about fentanyl. So fentanyl first came on, it was, when we first saw it, approximately 2.5 years ago, it would be mixed with heroin. So the substances we would buy as heroin would be partially heroin, partially fentanyl. The reason fentanyl became so popular, is the cost. It's much cheaper for the dealers to buy, so they make that much more money. There's that much more profit in it. And as you can see, it's 30 to 50 times more potent than heroin. There's different types. It's mostly made in China, and now we're getting much of the illicit fentanyl coming from Mexico across the border. They already have the distribution network set up for the cocaine and the heroin, so now they're just adding fentanyl to it. It's generally a white powdery substance. So again, when it showed up and mixed with heroin, now we see with cocaine, we're getting a lot of cocaine mixed with fentanyl. So folks are buying cocaine, or what they believe to be cocaine, and this is a pretty sad story. There's these three individuals. They went to a drug house. They went and thought they were buying cocaine. The younger female thought, she texted her friends. She was excited, I want to do cocaine for the first time. Well, it was cocaine laced with fentanyl, and that young lady died that night. The other person is still in a coma, and the third one finally came out of it. So the problem with now is people believe they're buying a certain drug, and many of these drugs are now tainted with fentanyl. And now even they're going to press it into a pill form now to try to make them look like oxycodone or oxycontin pills. So they're adding a cutting agent, they're pressing them into pills and selling them as oxys. So we talk about medical fentanyl. This is not the stuff killing people. This was the stuff that was being abused, though, prior to the illicit fentanyl. The transdermal patches, the injections. I had a minor medical procedure yesterday, and I'm on the gurney. They put the IV in my arm, and I was like, what is that? They're like, fentanyl, something else. And just when they said fentanyl, I was like, oh my gosh, no thank you. So, but the transdermal patches, people used to dumpster dive for them. So you put the patch on your arm if you're in chronic pain, and then only about 50% of that fentanyl will be used. Then you would take the patch off, throw it in the garbage, and these folks that were addicted to opioids would then cut that open and then suck out what was left of the fentanyl inside of it. So when we talk about fentanyl, we're talking about the illicit fentanyl, the fentanyl coming from China and Mexico, killing folks. So this is really unique how it's packaged. So one dosage of fentanyl or heroin is called a deck. It's a deck of heroin, and it's these little bags right here. They're about a half inch by an inch when you open them up, and they're folded over. And when they're folded over, they look like this, right here. And then what they do is they put 10 of them together, and that's called a deck. So a bag of heroin or fentanyl on the street right now is about $10 to $15, generally around $10 for one deck, and that would be one use of fentanyl / heroin. And it's always stamped. Anyone guess why it's stamped? Because it's a branding issue, and that's exactly what it is. People work hard on their brands to put out a form of opioid that is very strong. 'Cause nobody wants to take an opioid who's addicted to it that is not strong. And when you experience opioid addicts, always talk about how they can handle it. So what happens is these people die from overdoses of a certain brand. It actually drives that brand, becomes more popular. It was back when Bob Duffy was a chief. This is when we had 3 or 4 fatal heroin overdoses in a period of about a week and a half. And back then, that was a lot. Now, that's about average. So the panic bubbles hit, and we were braced with a decision. You put it out in the news that this heroin, Red Devil heroin is what it was, Red Arrow heroin. Do we put it out in the news to warn people, or does that do the opposite and drive it up? So we did, in good conscience, what we had to do was put it out. And again, our informants, all they talked about is everyone was looking for Red Arrow heroin. So it's generally going to have a stamp on it, and that's why folks hate putting out bad product. Then you get a discount for bundles. So you buy a bundle of heroin, which is 10 decks, you can pay about $80, and fentanyl. Now the price of fentanyl is so cheap for the dealers, we've been buying that for $50. You get 10 decks of heroin, 10 dosage units for $50. The cost is really driven down. And that's when Dr. Mendoza talked about the oxy problems. That's what kind of drove some of this towards heroin/fentanyl. So we talk about oxy. The 80 milligrams are the ones that are really sought after. That's some of the nicknames, OCs, hillbilly heroin. And you talk about the diversion of it. Very strong in Monroe County. It's been strong a long time. In many different ways it's diverted. Many times it's grandma and grandpa's or mom and dad's. It's their medicine cabinet that folks are stealing it from. Back in the early 2000s, doctors would leave scripts right there. People would go in and swipe a whole script. I've investigated bad physicians assistants we've arrested who have given away scripts for either money or other things. But the diversion is very strong. But what you have to realize is, and I've talked to thousands, literally thousands of addicts, and that when you talk to opioid addicts, almost all of them, the vast majority, have dabbled in prescription drugs before becoming an addict. However, everyone in this room has probably taken an opioid here or there, whether you had tooth work done or whether it was some medical procedure. And it doesn't mean that the overall majority of people who use opioids, prescription opioids, don't become addicts. So there's that correlation there. But this definitely, the overprescription hit almost it was like a perfect timing or a perfect storm for this epidemic. Because we do see, so what happens is these pills on the black market are about $30 for the 80 milligrams of Oxycontin, when you can go buy a deck of fentanyl/heroin for $10. So it was showed on Dr. Mendoza's chart where the prescriptions started coming down, but then heroin use started coming up because this is a cheaper alternative to heroin. So how is it consumed? We talk about this all the time. The main way fentanyl heroin is consumed is it's injected. So they put it in a spoon, sometimes a bottle cap. They add that's a powdery substance. They add some water to it. Then they heat the bottom of it with a lighter until it dissolves. Then a lot of times they'll take a cotton swab, a small cotton swab, put it in the liquid, then put the syringe in the cotton swab because it kind of filters out some of the contaminants. And then they inject it. The thing now with fentanyl being so potent is you can snort it and still get high. Back in early 2000s, you really couldn't snort heroin and get high, the kind of high that they want to get to satisfy their cravings and or withdrawal symptoms. But now we see a lot of folks snorting it and a lot of folks overdosing just by snorting fentanyl. And last, it could be smoked. They put it on a piece of tinfoil, light the tinfoil underneath it, and then suck it through a straw. So, in closing, what we've seen is it was never fully the heroin trade or epidemic. It was never fully engulfed in the city or strictly in the city. But what we see now is there's people selling fentanyl throughout the entire county. We're doing cases in Webster, Hamlin, Brighton, you name it. These tentacles are everywhere. Rural, suburbia, doesn't matter. The city, the folks we see coming into the city to buy it is, where all you folks live in the room. And it's really touching every corner of the society. And when you think about losing roughly 4 people a week, like it's truly an epidemic. It's horrifying. I was here for the crack epidemic, early 90s, firsthand, witnessed it. And as bad as that was, it wasn't taking lives like this was. I mean, still wrecking families, wrecking the community. When your car gets broken into and your purse is gone, that's not kids. That's a drug addict that broke the window of your car and stole your laptop or your purse. When your house got broken into and your TV got stolen, that's not a cat burglar. Those are drug addicts that need that money to fuel their addiction, to fuel that disease, truly a disease. That's all I have.